thank you once again for joining us for today's webinar on gastro challenges with scleroderma, a gut reaction, top to bottom. I apologize for the clock. It's 100 years old, and if I unplug it, it just dies. So we'll just wait for it. Thank you. We would like to thank our sponsors for making our webinar series possible. The Government of Canada's Emergency Community Support Fund and the Community Foundation of Nova Scotia. We do have a disclaimer. We in no way endorse any drugs or treatments shared within this webinar because it's recommended that all drugs and treatments be discussed with your physician for proper evaluation and treatment for your individual case. Thank you. Any questions that are going to be posed during the webinar will be answered by Dr. Pope after her presentation. Questions can be asked by using the Q&A icon, and these next couple of slides will show you where to find that icon on a computer or on a tablet. So bottom of the computer, top at the tablet. And now I'd like to introduce Dr. Janet Pope. Thank you, Dr. Pope, for taking time out of your busy schedule to be with us this afternoon. Dr. Pope is a professor of medicine and division head in the Division of Rheumatology at the University of Western Ontario, School of Medicine in London, Ontario. Her research includes studies in scleroderma, lupus, and rheumatoid arthritis. She's published over 500 peer-reviewed articles. She's received the Distinguished Investigator Award from the Canadian Rheumatology Association, Rheumatologist of the Year from the Ontario Rheumatology Association, Department of Medicine Research Achievement Award, and the Dean's Award of Excellence in Research. She's also been inducted into the Canadian Academy of Health Sciences. And as I said, she's a busy lady. Thank you once again, and over to you, Dr. Pope.
Great. So thank you everyone for attending, and we'll have lots of times for questions and answers. And I think my first disclosure before I show the usual consulting I do is that I am a rheumatologist, not a gastroenterologist, but I must say that my patients with systemic sclerosis, scleroderma, have taught me an awful lot of what goes on in the bowel with systemic sclerosis and sometimes how to treat it effectively. So these are some of my disclosures, consulting for companies and things like that. So I really want to discuss the different ways that scleroderma affects your gastrointestinal tract, or what we consider your gut or your GI tract, and about the symptoms and their treatment, because there are different symptoms and sometimes the treatment sounds like the same. You go, someone has diarrhea, someone has constipation, and we sometimes tell them the same thing if it's related to the same problem. And we divide up the gut really from the top to the bottom. So everyone knows so much that's on this call of how scleroderma has affected your life or the lives of the loved ones around you. So the physical health, your personal life, social life, and especially with COVID, mental health, because it takes more of a toll if you feel isolated. And it can affect all these different areas, from your ability to work, oral hygiene, opening your mouth, breathing and shortness of breath, itchy skin, heartburn, difficulty swallowing, overall quality of life, your Raynaud's, which is your fingers going white and blue and red in the cold and getting finger ulcers at times, diarrhea, acid reflux, constipation, bloating, incontinence, aspiration into your lungs, sometimes from the GI tract, dry mouth, the skin scarring and changes where you can't bend your fingers right, pain, fatigue, poor sexual health with dryness and pain and poor sleep. So really not having as much desire potentially, but also for erectile dysfunction in men and systemic sclerosis patients is quite common. Depression, hand disability, and various organ involvement. And this isn't even inclusive. There's just so many areas that scleroderma can affect you. And if we look at a diagram of a person, obviously lungs are important, scarring on the lungs or pulmonary arterial hypertension, kidney crisis or scleroderma renal crisis, very rare. GI, though, really from top to bottom, reflux with acid coming up your swallowing tube, food sticking, which is called dysphagia, constipation, diarrhea, bloating, malabsorption, so weight loss, colonic problems with incontinence or even rarely perforation of the bowel, heart involvement, the skin and the Raynaud's that we've talked about, inflammatory arthritis, muscle involvement, and just so many different areas. But when we ask people how they're doing with scleroderma, a lot of times they'll say their Raynaud's and digital ulcers, their skin problems with tightness, itchiness, and their GI tract are often the three most symptomatic areas. And the gut, really from your salivary glands where you make secretions to help digest food. So amylase in your parotid and salivary glands, your swallowing tube, liver, not so much affected, but some people with scleroderma can have also primary biliary cholangitis. That's a little bit more common in scleroderma patients, but not most. Gallbladder, not so much. Pancreas, not so much. But stomach, small and large intestine, and anus can all be commonly involved in people suffering scleroderma. So I'm going to really start from the top and go downward. So the mouth in scleroderma, so many people can't open their mouth wide. So to get a big sandwich into their mouth is difficult. Dry mouth, so problems swallowing because there's discoordinated swallowing, but with dry mouth, it's more difficult. Sjogren syndrome is autoimmune dry eyes, dry mouth, but even you can get collagen or scarring, fibrosis laid down in your glands that make secretions in your mouth, and therefore they can be dry for that reason. Then acid reflux can be terrible. The taste can give you bad breath. It can damage your teeth, but also it's very difficult to brush your teeth properly if your hands don't bend right to hold that toothbrush, if you can't open your mouth wide. And even the dentist or dental hygienist will say, oh, it's very difficult to clean your mouth because you can't do a big wide opening because of scleroderma affecting the tissues around your mouth. And then the poor quality saliva. Our saliva is also antibacterial, so it can worsen problems with your teeth, and it can worsen the swallowing if it's already discoordinated swallowing. So the treatment really at the top end of your gut, your GI tract, including your mouth and the top end of your swallowing tube, is to avoid acid reflux, which we'll talk more about. Frequent dental care, so going to the dental hygienist more often, trying to get drugs that can increase your secretions or rinsing your mouth out more, or drugs that increase the motility really from the top of your swallowing tube and lower down, which we'll talk about, and drugs to increase saliva or lubricating the mouth. There's a drug called pilocarpine, or the other name is Salogen. And it helps to make more secretions, but it can sometimes give stomach upset or diarrhea. So not everyone finds it helpful because of side effects. And some people will tell me they lubricate their mouth because it's just so dry with all sorts of things with edible products. So with coconut oil, with sometimes olive oil, and they just swish it in their mouth and spit it out, and it coats their mouth for a bit of time. But it's not a long-term solution, but it can be helpful in the short term to help people. So this is a person with that Sjogren's, the autoimmune dry eyes, dry mouth, but in scleroderma, it can happen from autoimmune and overlap, but it can also happen because your salivary glands become scarred up. So basically, it can cause quite a dry mouth. So edible oil, treat if there's thrush, so a superinfection with yeast, which is often always white. Sometimes it's beet red. Preventing oral decay. So good mouthwash, especially if it's not too astringent. So sometimes mouthwash like chlorhexidine, sometimes those mouthwashes that are kind of expensive but are made to be more gentle. So the biotin products, avoiding sugar, going to the dentist more often, getting fluoride trays, and not drinking bottled water because bottled water doesn't have much fluoride in it. And believe it or not, drinking soda water. And if you don't like soda water, a half glass a day kind of thing, you can put it in your water bottle with water. And that's because soda water is sodium bicarb. It's basically baking soda in it. And that can help dissolve the small particles left on your teeth to decrease oral decay. So that could be helpful. Now, Elizabeth has a question. Can we make these slides available? Absolutely, yes. So we've already given a PDF to Atlantic Scleroderma Group, and so you can get it that way, no problem. So absolutely, yes. So that's good. Okay, so treatments. So some people will have both dry eyes and dry mouth. So good dental care, but not over drinking water. But sometimes you have to drink water to help propel the food down, especially if your mouth is dry. And then things if you have dry eyes, which isn't part of your GI tract, but artificial, some other eye drops like Restasis, and also ones that have hyaluronic acid in them to help sort of soothe your eyes, plugging your tear ducts, things like that. And fish oil can help a little bit in secretions and dry eyes. So fish oil over the counter might help a bit, but usually doesn't help much, to be quite honest, unfortunately. Yeah. So there's some of the potential treatments. Okay, what about the gut? We're really going to talk about the esophagus next. That's your swallowing tube. Then we'll talk about some of the other areas. So basically, nearly everyone with systemic sclerosis with scleroderma will have their GI tract, their gut involved. So about 90% of patients. It can be any site. It especially likes to be starting below, behind your breastbone. So behind your breastbone with dysmotility and food sticking, but it can be the entire swallowing tube. And for the swallowing tube, that means food can stick. Bottom of your swallowing tube, the bottom of your esophagus, the sphincter can be inappropriately open, so acid can come up and give heartburn and even into your mouth, and it's quite a horrible feeling. Reflux disease is far more common in scleroderma, far more severe in scleroderma. Severe gut involvement is about 8% of people, and it causes a lot of symptoms. It's kind of an awful thing to deal with when you have tummy pain, severe cramps, bloating. Obviously, if there's incontinence of stool, that's a horrible situation. So this picture here is the sideways view of a picture where someone swallowed barium, and this is a scleroderma esophagus. So you can see instead of a nice pipe that should be the same diameter all the way down, it's super dilated at the bottom, and that's because of the scleroderma. So that's called a scleroderma type esophagus. And then the bottom picture is looking down before it's the bottom of the swallowing tube, and you see that redness, that's erosive esophagitis. So not ulcers yet, but irritation and bleeding, and the mucosa, the lining isn't as good, so it can break down more, causing blood loss and sometimes obviously pain. So the esophagus and the stomach are the upper tract of your upper GI tract, and it's pretty frequent. So these are data from our Canadian Scleroderma Research Group, and some of you might be involved in that because Halifax is a center. New Brunswick doesn't currently have a center, but did in past. So basically this is looking at almost 1,000 patients. Their disease duration was about 13 and a half years. They were about 55 years old. And of course, most were women, about 85% were women, 15% men. So overall, gastroesophageal reflux disease almost 3/4 of people, and needing a dilatation. So someone to go in and stretch the bottom of your swallowing tube, which sometimes helps if there's narrowing from the acid reflux causing inflammation and narrowing, or from just the dysmotility itself. About 1 in 6 people will need a dilatation. And you can see it happens in both our subsets, the diffuse, which is more skin involvement, or the limited cutaneous systemic sclerosis, or what some of you know of as CREST syndrome or limited scleroderma, common in both groups. So this is a tracing on the top of the swallowing tube contractions of a person with scleroderma. And on the bottom is a regular healthy person without scleroderma. So the bottom of the swallowing tube, you can see there's good, strong, coordinated contractions throughout the swallowing tube. Whereas in scleroderma, it looks like almost a flat line. Why? Because every part of the swallowing tube can be involved. The muscles to make contractions, the inner part of your swallowing tube below the lining can be scarred up, and the nerves that go to make the contraction can also be scarred around them. So sometimes instead of a nice organ that's a muscle that should be contracting well and in a coordinated downward fashion, it's more like a lead pipe that's dilated at the bottom, but just one stiff lead pipe. So this is a big deal in a lot of people, and almost everyone with scleroderma will have some changes in their swallowing tube, even if they don't have symptoms. But you saw 3/4 will have symptoms of gut involvement. So the discoordinated or uncoordinated contractions, the lack of that tightness or strength of the contractions. The acid reflux is made worse because the bottom of your swallowing tube, the lower esophageal sphincter, has scarring. And so instead of closing when you're done swallowing, it should close naturally. It's inappropriately open, and your stomach doesn't contract right. So stomach acid and contents can come up the esophagus, which leads to bad acid reflux and can even go in your mouth when cause aspiration. And esophagitis would be having lots of inflammation and blood loss and pain often at the bottom of the swallowing tube. We treat it with proton pump inhibitors. So that's your esomeprazole, omeprazole, rabeprazole, lansoprazole, pantoprazole. Those proton pump inhibitors are what you know of as Losec, Periet, Prevacid, Nexium, those drugs. And we often go double, triple, and rarely 4 times the dose, because there is a dose response that can go upward and help some of our patients. So again, in the general public, most people use a proton pump inhibitor 1 dose a day and they're fine, or 1 normal dose. Sometimes we have to double, triple, or quadruple it. We sometimes add H2 blockers. So that was like ranitidine, that was Zantac, that was off the market for a bit. There's also, it's back on the market, cimetidine, famotidine, that's called Pepcid. So those sorts of drugs, in addition to the proton pump inhibitors, can be helpful. Not eating after supper, avoiding all the things that are that set you off, like alcohol, chocolate, coffee or tea, spicy foods. If they make it worse, you avoid them. You don't eat after supper time. You raise the head of the bed, so either a wedge pillow or getting blocks under the bottom of your headboard to raise it up, and avoiding the triggers. So some people say, oh, when I'm having a really bad spell, I can hardly eat even after 4 o'clock in the afternoon because it bothers me, whereas other times I can eat my supper at normal supper time. You can, because of acid washing up a lot into the bottom of the swallowing tube, you can get that your stomach lining starts growing into the bottom of your swallowing tube, and that's dysplastic or abnormal, and that's called Barrett's esophagitis. And if you have that, you need a scope to look down at that lining every 2 to 5 years, get a biopsy, and make sure it's not turning into cancer. It would rarely rarely turn into cancer. And if someone has these changes, the GI doctor, the gastroenterologist, or the general surgeons, if whoever's scoping you, will say, oh, remind, like put on your calendar, you need an upper endoscopy every so many years. I have not seen Barrett's esophagitis go to cancer, like adenocarcinoma of the esophagus, now in probably 2 decades. And I think it's because we use so many of the proton pump inhibitors. It's so much better for the swallowing tube not to go into that change. But Barrett's itself is a precursor. It doesn't mean you'll get cancer. It means you have to be watched. So there's lots of things that can happen. So you can have at the top, it looks like a watermelon, the outside of a watermelon. So that's called watermelon stomach. And the blood vessels get all kind of dilated, and food going on them can make you bleed. So it can be asymptomatic, and you can present with low energy, iron deficiency anemia. And so GAVE is called gastric antral. It's in the antrum part of the stomach. Vascular, it's the blood vessel. Ectasia, funny blood vessels that are dilated, that bleed upon food or contractions of the stomach, or when the acid comes into the stomach. And it's treated by, they laser the heck out of it. They just keep scarring it up with laser, and you need usually multiple laser. It's covered by the government and everything. It's appropriate care. And we have to sometimes give iron, rarely blood transfusions, sometimes even intravenous or intramuscular iron, because you keep leaking low levels of bleeding over and over and over until it's fixed up, and then it can recur later. So if someone's anemic and had this 5 years ago, I say we need another scope if I don't know why you have low blood. Then in the stomach, your stomach, just like the swallowing tube, does through the, and then sometimes there's dumping. You feel bloated, you feel hungry, you feel hungry, but you eat and you're full early. And then you get all shaky because all of a sudden your food that's sitting in your stomach for a day or two instead of for hours just dumps out. And then your blood sugar goes low. So delayed gastric emptying, bloating, feeling full early, all that can be a problem. So how do we treat? So the watermelon stomach, we have to diagnose it, often laser, and to scar it up so the blood vessels scar down and don't bleed. For the delayed gastric emptying and the swallowing tube issues, we sometimes have to give also drugs that increase contraction, so promotility agents, and I'll talk more about that. Then you can see in the bottom here, there's a lot of scarring going on in the stomach where they've lasered someone with the watermelon stomach. So bloating, feeling full early, that's called early satiety. And when you're bloating, you can have intermittent diarrhea. So you can say, I'm constipated, then I get gassy and painful, and I feel like I feel pregnant, I look pregnant, great big belly, and then boom, you can have diarrhea. And that's because with your food sitting in your stomach for a long time, there's more the food's sitting there, so we have more bacteria trying to digest the problem. And because we try to neutralize the acid, because your acid reflux, the proton pump inhibitors and the H2 blockers lower the acid to not get erosive esophagitis. So we're lowering the acid in the stomach. Bacteria would be killed by acid. So some of our treatment is allowing more bacteria to grow. So when you get too much bacteria, you just dump it out of your stomach and start over. So we do give, if it's bad enough, rotating antibiotics or intermittent antibiotics to knock down the bacterial count. And rarely will someone need antibiotics all the time. That's very rare. But some people need an antibiotic a week every 3 months, or a week every 2 months, or something like that. And we do drugs to increase bowel contraction. And you go, you want to give me something to make my bowels contract when I already have diarrhea? But it's diarrhea because your stomach's like a lead pipe, not contracting like a good muscle, or like a scarred up stomach. So with fibrosis or collagen in the muscle of the stomach. So we sometimes give erythromycin, which would give your friends or maybe your kids or your partner diarrhea, but for you can help diarrhea by getting rid of bacteria and making the contractions better. But there's all sorts of antibiotics we can use, especially if you're not allergic. Inexpensive ones like amoxicillin or ampicillin, tetracycline, or the erythromycin, rarely ciproflox, because it's we don't want to get bacterial drug resistance for other people, such as people with obstructive lung disease. So usually not ciproflox, but it could work well. And also metronidazole or flagyl. So lots of different antibiotics and others. We want, sometimes we use drugs for irritable bowel, not because you have irritable bowel. If you have these complaints or these symptoms, it's to help the contraction. So I use percoloprolamide, which is Risatran, but it's not covered on most government plans. Zelnorm, which is for the large bowel. There's another one that helps contraction for constipation. That sometimes helps us because it's making contractions be more normal. Sometimes probiotics will help, but in honesty, the lactose intolerant. So you take yogurt with probiotics and you might actually get more problem. But buying probiotics are usually in the fridge of the pharmacy or of a more about that in a second. Then you can have beyond the stomach, now you see around the belly button there, and you see on the x-ray, the great big loops of bowel, because there's a lot of air in the bowel. So diarrhea, gas, bloating, weight loss, poor appetite. You can have a bowel obstruction. So all of a sudden you're not getting gas. You're not getting bowel movements, and then you start vomiting, and you're vomiting. There's nothing in your stomach. So even vomiting lower contents. And that more severe variation is often far less common, thankfully. You can even get twisted bowel because it's just all bloated and not moving much, which would be very uncommon. A bowel perforation is very, very rare. Malabsorption, though, and malnutrition. It's hard to eat when you're always feeling so bloated like that. You don't feel hungry. Your stomach is pushed up. And malabsorption, you can have greasy stool or such sometimes severe diarrhea that you're pooping out food that isn't even digested. Or sometimes people will say, I can actually see some of my pills in my diarrhea because I'm just not absorbing anything because the bowels are dumping. So they don't contract right, but then they don't over contract. They just are like almost like going down a slide. They just allow food to come right out or stool to come right out. So we treat with prokinetics, and that's the same with the delayed stomach emptying or the very severe acid reflux. Prokinetics would be your domperidone or Motilium, Maxaran called metoclopramide, or percoloprolamide, which is also called Risatran. They're the types of drugs I use. If you have severe diarrhea, I might use the things that are over the counter like Lomotil or prescription loperamide to stop you from getting the diarrhea at times. And rarely we would use narcotics because they can constipate. But if you have constipation and diarrhea alternating, you don't want narcotics because that makes the constipation worse. There's a drug called octreotide, which can be given under the skin. It's an injection. It's a hormone to help the bowel contract more normally. I think it's expensive. I think it's painful. And I don't think it works very well, but we tend to use it as a last resort. So it's hard for things to work if nothing else is working. We might get a nutrition person involved. So whether it's a dietitian or a gastroenterologist with an interest in nutrition to help you out. Rarely we would need to put the stomach to rest, an NG tube going down your nose to rest the stomach and suctioning out what's in your stomach. Rarely we would need parenteral nutrition by a feeding tube or by an intravenous. So those things are rare. But GI rest and nutrition by other routes does occur sometimes for people. This is fortunately, it's annoying for people, but fortunately, usually not as severe as some of what I'm talking about here. But we have a lot of tricks. We also don't want to always, sometimes we want to bulk up the stool if you have a lot of watery diarrhea, or if you have fecal incontinence, and bulking up the stool like with bran, but that's not always the right suggestion for everyone. Sometimes we use FODMAP, FODMAP diet. And again, that's not for everyone either. So there's different things that we can do to help. So we've asked experts what to do and published and looked at the various areas. So these are scleroderma experts, not GI, not gastrointestinal or GI experts, but they said for the acid reflux, the upper GI, high dose proton pump inhibitors, then add promotility agents, then think of scoping, see if a dilatation will help. So even if you don't have a narrowing, because if food is sticking all the time, often right under your breastbone, a dilatation can help by the scope and going down and dilating. But even if you don't have a narrowing, if you have poor contraction and food is sticking, sometimes a dilatation helps. And we don't know if it gets the peristalsis of the contractions back on track a little bit. So when it helps for some people that don't have a narrowing, I don't know why, but it's worth a try if that's what your general surgeon or gastroenterologist thinks. And then rarely would we do surgery or recommend surgery. I wouldn't do it because I'm a rheumatologist, but surgery to wrap the bottom of the swallowing tube with your stomach, because then you can't actually burp. And if you food sticking, you have to try to, would be very rare in my patients. And for the small bowel, for bacteria, I mentioned lots of different antibiotics, like ones I mentioned. There's rifampicin, a lot of plans, and it's expensive, so that's why I didn't mention it. If there's an obstruction, motility agents. For the watermelon stomach, the laser. For constipation, laxatives, maybe drinking a bit more fluids, not getting behind on fluids. Incontinence is a real problem to deal with. So sometimes biofeedback, sometimes there's even at tertiary care centers, we don't do it here where I am in London, Ontario, but in Toronto, they sometimes give an implantable stimulator to make the anal sphincter contract. So that's something that can be done. For malnutrition, we try to feed people orally if at all possible, to give nutrition in other ways. The promotility drugs I talked about already. So that's what we kind of think about. So bloating, feeling full early, and intermittent diarrhea. Sometimes this rotating antibiotics for small bowel overgrowth. We still have to use the proton pump inhibitors if there's bad acid reflux, but that allows bacteria to grow. And then maybe probiotics that we talked about. Then in the colon, you can have problems in the colon. So this is the bottom of your, like your, at your rectum, you also have then your anal sphincter. So looking down in that area, here's a regular person where you can see the muscle areas are well defined with areas around. You can see in someone with scleroderma, you can't find the muscle layers as well. It kind of all blends in together. And so the anal sphincter of the scleroderma person just isn't as tight, and the bottom of your colon can dilate because food isn't contracting. Like your food can sit there. Well, it's not food by the bottom of your colon, but the fecal matter can sit there, and you can get dilatation there. So then people will have sometimes incontinence, which is very, no one wants to go out if you're not sure what's going to happen. They don't want to go out to eat. They don't want to go out for a long walk. So we also teach Kegels exercises, which if any of you have had a baby, it's what you're supposed to do after a baby, to squish your butt together, your bum muscles together, and tilt your pelvis. And doing that literally hundreds of times a day, holding it just 30 seconds each time. You can do it on a walk. You can do it sitting. You can do it at work. You can do it while you're watching TV or listening to a podcast. No one knows you're doing it because it's not like lifting weights where it's obvious. that can sometimes help if you're prone to fecal incontinence, because that's really distressing for people. So if there's a lot of constipation, we give laxatives, usually non-stimulant. So Senna tea could be used. That's more a stimulant. Dulcolax, PEG. There's a lot of different laxatives. We can, if you're getting a lot of diarrhea with it, that's low motil or low paramoid, the things that help for diarrhea. Biofeedback can sometimes be helpful. Sacral nerve stimulation, not widely available. And rectal prolapse repair. Surgeons don't like going in that area because they're not sure if someone with scleroderma will heal right. So there are things that can be helpful. I've had a patient be so upset about this that she was very social. She became more homebound. She got depressed. And we were able to help her with Kegel's exercises, pushing your butt muscles, your gluteal muscles together and tilting your pelvis. That helped a bit. And changing her diet to the FODMAP diet, which you can look up, was helpful for her too. And now she goes out more. Of course, as she was getting better with all this, COVID came. So then she felt housebound from COVID, but it has helped her a lot. But there's no easy fix for this. And we need sometimes to know with a rectal exam or a scope what's going on so we can actually treat the issue as best as we can. So pelvic floor exercises, regulating the bowels to avoid diarrhea and constipation. So sometimes you're taking a stool softener like Colace, the red capsule, and then you might be using something for constipation and then something at a different time for diarrhea. So it gets tiresome for people, but it's a very distressing problem, but fortunately not too common, but distressing if you have it. So we do have guidelines, and we looked at guidelines in the treatment of scleroderma, including GI. And so these are guidelines and looking at how well our Canadian Scleroderma Research Group patients had the guidelines adhered to. So 85% of our scleroderma patients of over 1,200 that we looked at were on the proton pump inhibitors for acid reflux. The prokinetic, or the things to increase motility, we had about half our patients on them, different ones at different times. And treating malabsorption due to small bowel overgrowth, that's usually only people, we don't have to test. So you can do a hydrogen breath test for small bowel overgrowth, not widely available. They have to order it in. It's a nuclear medicine test. I just treat on spec. So in other words, I treat, if it sounds like you have small bowel overgrowth, I use antibiotics, and if it helps, great. So ever used, 1 in 6 of our patients were on small bowel overgrowth treatment. So it's not as common as acid reflux or dysphagia, which is very common. So the most common is your swallowing tube. But for small bowel overgrowth, 1 in 6 of our patients have needed treatment for that. And concurrent use was about 5% of our patients. So some people are just on it rotating or just need it rarely. Some people need it frequently, but not most. So it gives you an idea. So swallowing problems can be associated with worse lung function because you can aspirate into your lungs, which is another good reason not to eat after supper time and to raise the head of the bed. So we do know that people who have had more swallowing tube or gut esophagus problems have or have needed to have their swallowing tube dilated, have a lot of swallowing issues, food sticking and choking, will get more aspiration into their lungs and worsen their lung issues. So not everyone with this will have lung issues, but if you have interstitial lung disease and swallowing issues, your interstitial lung disease could be worse if you're aspirating. And so we found that if you're aspirating, so we say, do you wake up choking on acid in your mouth? Have you had a recent need for getting your swallowing tube dilated? Those things increase the chance of worsening your interstitial lung disease, your lung inflammation or fibrosis, your lung scarring if you have it. So In conclusion, GI involvement occurs in nearly everyone with scleroderma. So acid reflux, about 95% of our patients. If you don't have acid reflux, I think you probably have it and aren't symptomatic almost. It's so common. 80% to 60% rarely will have dysmotility, where they say, oh, I have food sticking, and it can be mild, moderate, or severe. The most common GI involvement is acid reflux, and then the problem swallowing, and then delayed stomach emptying. Many symptoms such as heartburn, food sticking, which is your dysphagia or food sticking, feeling full early, bloating, and diarrhea are treatable somewhat, or are highly treatable for some people. And if you're having a lot of acid reflux, you could aspirate into your lungs, which can worsen your lung disease, which we don't want. So a lot of my work has been funded, including the Scleroderma Society of Canada and Scleroderma Society of Ontario, and many other scleroderma provinces have contributed to the Canadian Scleroderma Research Group. So I thank everyone for that. And I thank my patients for allowing us to do research on them to get more answers for people. So I'd like to stop there, and we have lots of time for questions. And I can unshare my screen, maybe stop share. So we do have some questions here, and I can start with questions. So Angie says, can eating actually calm down the bloated feeling? It seems like an oxymoron, but it seems to happen to Angie. So when you're really bloated, sometimes it's gas. And if we eat, in a person without scleroderma, like think of little babies. When they eat or breastfeed, we little babies, they often poop. And that's called gastrocolic reflux. You eat and you get contractions going in your gut, your GI tract. So little babies will eat, then poop, eat, then poop. And as we get older, that doesn't happen quite as much. So I think if someone's really bloated and eating helps, it probably calms it down, because they probably still have the signal from their brain to their GI tract to actually get contractions going. So that's probably why it helps. Can GI problems somehow increase Raynaud's phenomena? Maybe. I don't think so directly, but when we're getting blood flow to our gut, we might be, especially if it's cold out and you're going for a walk, we might be more constricted distally, which is our head, our hands, our feet. So if you get a lot of Raynaud's, when you're getting more internal blood flow to organs like your GI tract, you can get more constriction to your hands or your feet. So not commonly, but it might worsen Raynaud's in some people, especially if it's cold out or you're eating something really cold. So Susan's saying, so when would you know if you should have a round of antibiotics? We don't always know. So I often say, is this distressing enough, the bloating, gas, dumping, diarrhea? Because the dumping is cramping and painful for people, or they feel really shaky because they've had this whole boost of glucagon into their stomach, which can lower your blood sugar as you're trying to digest. And then all of a sudden, food that's been sitting there a long time dumps out. So it's very problematic. So if people have a lot of feeling full early, and especially I'll stand here, especially right here at the upper bowel, not at the belly button where I showed you the bloated person, it's worthwhile to ask your doctor, especially a specialist, should I try a course of antibiotics to knock down my bacterial count? So it's called SIBO, SIBO, small intestinal bacterial overgrowth. So do I have too much bacteria in my gut? And you can say, well, the doctor on the weekend, or, I heard this talk and I wondered if I should try a course of antibiotics for this. And if they're not certain, someone might send you to a GI specialist, a gastroenterologist, to kind of discuss it. So we don't need fancy tests for this. It's a clinical diagnosis. And if antibiotics help, we say, okay, great. It might come back. It will come back. In fact, for most people, how long does it work for? So great question. Okay, when would you know, This is someone saying, what was the liver condition I referenced and what are the symptoms? Okay, so we're doing research on this right now, but it's well known already. So about 3% of our patients with scleroderma, especially the limited, not the diffuse subset, so the CREST syndrome patients or limited cutaneous systemic sclerosis, especially the positive anti-centromere antibody patients. So not most, about 3 to 5% of our patients with scleroderma will have PBC, primary biliary, it used to be called primary biliary cirrhosis, but it's not always irreversible damage to the liver. So it's called primary biliary cholangitis, and that can make you itchy. So if you're itchy, and or if you have an ELK phos elevated, or you've had, say, an abdominal ultrasound and the liver looks funny, funny meaning it might look nodular or small from scarring, or rarely large, then they might say, could be a liver problem, consider doing some tests. Then we do this anti-mitochondrial antibody. And if it's positive, we get a GI doctor to confirm the diagnosis of PBC. So in people with PBC as well, about 3 to 5% have limited cutaneous systemic sclerosis, so scleroderma or Sjogren syndrome. So that's a great question, but that's the main liver thing. You could have fatty liver, but not per se with scleroderma or the drugs usually. Some people with scleroderma with inflammatory arthritis or moderate skin involvement are on methotrexate, but scleroderma patients aren't at higher risk of methotrexate damaging the liver or causing fatty liver. So mostly your liver is kind of spared for most people. Okay, so Adonna says, why does my gut hurt every time I eat? What can I do to stop it from happening? So your gut is a big area, so it depends on what it is. So it might be feeling full early and that nausea or contractions that happen. That would be a promotility agent. It could be acid reflux, but that you usually know because you feel it at the bottom of your swallowing tube, right below your right behind your breastbone. So if it's acid reflux, which you usually know that because it feels like heartburn, or it is what people call heartburn, we give a proton pump inhibitor. If it's your stomach not contracting right, we often give a promotility drug. We might say eat frequent small meals, lunch, snack, supper, breakfast, snack, lunch, snack, supper, but no snacks after supper because we don't want acid reflux. So you could ask your family doc or your specialist, if you have a specialist, my gut hurts every time I eat. Is food stuck in my stomach and what can we do about it? Sometimes if you give the cue, they know, oh yeah, we can give metoclopramide or domperidone, or which is Motilium, metoclopramide is Maxaran, or Risotran. So there's things that can be used. Okay, does being hungry cause bloating of the stomach and the bowel? Well, not really. If you have friends that are hungry, they're usually not bloated. But when you're bloated, often there's gas and stuff, but you can still feel like, oh my gosh, I'm hungry. Because every time I eat, I'm more bloated. So I don't eat as much. So I'm hungry, but now I'm more bloated. So when I start eating, it worsens. So it can be a vicious cycle. But hunger itself shouldn't make you be bloated. Can scleroderma affect your nasal passages? Not so much, but when you have dry eyes, dry mouth, if you have Sjogren syndrome with it, the autoimmune or the scarring, fibrosis, dry eyes, dry mouth, you might have less nasal secretions, but not usually. And it shouldn't affect your sinuses. Okay, so Susan's, so that's Catherine, thank you. Susan's saying, does bowel issues present itself as cramping? Yes, it can. It can be quite painful. So you might have a friend or you might know something about someone with inflammatory bowel disease. Scleroderma it's not Crohn's or ulcerative colitis. It's nothing like that. But some people with inflammatory bowel can have cramping, gas, and they can kind of relate to what you're saying, even though it's from a different pathology. And some people with diabetes, their stomach doesn't dump, it dumps out the food and doesn't contract right. And so they can kind of relate too, but that's usually a very uncommon complication of diabetes. But yes, cramping, and it can be painful. And if it's way lower bowel cramping, we'll treat it differently than if it's by your belly button. So we need to know what area of the bowel so we can kind of treat it. Okay, so another question so Susan had C. difficile. The antibodies are antibiotics an increased risk of Clostridium difficile? And yes, they are. So antibiotics, particularly certain ones, can increase the chance of getting a bad bacteria growing more and giving bloody bowels in your colon. But there's some antibiotics are higher risk than others to cause that. So I am careful giving rotational antibiotics and avoiding some in certain things like vancomycin, things like that. So it can increase, any antibiotic can increase C. difficile, but some in particular. Good question. These are all great questions. So Julie's saying, how successful have we been? Have I seen scleroderma patients gain weight back after all these issues? Just started on antibiotics for small bowel overgrowth and dumping and diarrhea and constipation, but have lost tons of weight over the last year. BMI is actually in a really low body mass index, and it's a struggle. Seeing a GI specialist. So you might ask the GI specialist, should you be on a FODMAP diet, but you have to get in enough calories. You might look at frequent small meals, and you might even have to look at bowel rest, and not a permanent, but sometimes temporary feeding where you can still eat a bit. But we don't usually do a feeding tube in the stomach because you'll get acid reflux back. It's called a jejunal, a JT or jejunal tube, and that can help some calories and maybe help someone get to a better weight. So it's something to ask, and that is very subspecialty. Your rheumatologist would say, I don't know, ask your gastroenterologist, or your general internist would say, ask your gastroenterologist. But yes, I've seen people gain weight back, but it's a struggle. Sometimes we put them on medium chain triglycerides to get calories in, but they taste terrible. So it's usually not something people want to take orally. So great question. Samantha says, considering the limits of the drugs used to treat the GI symptoms like proton pump inhibitors, should we look at specific dietary guidelines? Yes. So if something sets you off, avoid it as long as it's not like something you absolutely have to have for nutrition. So, chocolate, peppermint, caffeine, spicy foods, but some people, anything and everything triggers them. Other people, they say, every time I eat my favorite steak dinner, I can't swallow it. That's a problem. And I'm just making this up as a, for instance, and I always have digestive issues. Then you know what we'd say, stop eating it, even though it used to be your favorite. So great question. Should we avoid using Imodium or Pepto-Bismol with diarrhea? So Pepto-Bismol, if your kidneys work fine, is fine. And you can use Pepto-Bismol tablets. So if you had regular bowels, your bowel could get lazy being on Imodium all the time. Our people with scleroderma who need Imodium might need it all the time, indefinitely, or for months or years at a time. So we don't mind. We just say use it if that improves your quality of life, because your bowels aren't going to go back to normal anyway. So use it if you need it. And yes, with a lot of diarrhea, you can get pain. So rectal or anal area pain around your perineum, kind of like diaper rash there. So you can use just like diaper rash, the zinc products, the cream that looks white that we use on a baby's bum. You can certainly put it around your, like it's on the outside, you can put it around your anus. You wouldn't put it on the inside, and that might be helpful. And then trying to keep dry there. Some people have very, not very astringent wipes if they go out to just help like to clean around there. Just like you need more dental hygiene, sometimes you need more of the perineum hygiene or the rectal area. So Karen says, I had zero motility in my esophagus. Lower esophageal sphincter is stuck or calcified open or stuck open. PPIs make the pain worse. And lately I have constant pain in my stomach to my throat. Tums will help it because Tums is calcium to help it a bit to neutralize acid. So what's the next step? The GI doctor said, I go to a GI doctor, not a rheumatologist. The GI doctor is better at this. So I think, and then there's also other problems, obstructive lung disease, diabetes. So we have to try to keep healthy diet. You're going to need puffers maybe for the obstructive lung disease. So other things that can be irritating, but rarely someone might need a actual surgical procedure, the modified Neeson or modified Hills procedure. They're names of the procedures, people's names. But You could ask, but you probably do need more anti-reflux because you're getting burning going up your swallowing tube. So although proton pump inhibitors might make it worse, you probably actually need 3 or 4 times a proton pump inhibitor dose, and you probably need a pro-motility agent. So that's what I would ask about. And you can just sort of write down some of those things, especially if you look at the PDF later. Okay. What does intermittent antibiotics mean? It means sort of a 5 or 7 day course of full dose or partial dose antibiotics and then not used for a while. So I have some people that I have a prescription with 5 refills or rotating antibiotics, and they might need to fill the prescription, once every 2 months. That would be intermittent. And some people need it all the time or every month or every 2 weeks, but they're the rare people. That's more severe. Okay, does reflux cause the feeling of heat coming from your stomach? Maybe. Because heat, it's often coming, not just it's coming behind the breastbone and up into your throat as well sometimes. So it might be. Are there indications for urgency when changing positions in bed? If lying on the back to the side, it feels like you need to poop all of a sudden. And that's because on the side, might depend on what side you lie on. The bottom of your rectum is dilated. Often if you've had fecal incontinence, like if you've had leaking of stool or leaking of poop. So you might want to lie on the other side, see if it makes it better, because there are nerves that on one side are innervated, like you get more of a signal on one side than the other. So you might want to move around. Okay, so that's a good question. And doing the Kegels exercises is important, and trying to poop before bedtime might be important so that you don't wake up with this urgency and pain and stuff, or with an accident, a stool accident. Okay, does gallstones increase reflux problems? Not really, no, but we're all prone to gallbladder problems just because, but not because of scleroderma. Would the ALT test show an indication of the liver issue? Maybe. So ALT can be increased for liver issues, but ALTs are increased in a lot of people and don't have a huge meaning, but maybe. So if your ALT is always abnormal, someone's probably already done an ultrasound of your liver and or a FibroScan. Is redness an inflamed feeling at the back of the throat an early indication of esophageal involvement, not as a result of acid reflux? Not necessarily. So you can be inflamed at the back of your throat, or it can look like cobblestones because of postnasal drip. So not necessarily. So that's where you'd maybe ask your family doc, can you figure out what this is? Or do I need to see an ear, nose, throat person to look at the back of the throat more thoroughly? So good, like, again, all these are great questions. Samantha, what are the most important nutritional advices for systemic sclerosis? Try to eat a healthy diet, though sometimes high fiber diet, and some people make things worse and other people help them. Don't go on to weird fad diets. And if it upsets you, like your stomach or your swallowing tube or whatever, then try to avoid it if you don't need it. If you've lost weight, you got to see your family, like lost weight without trying, see your family doctor or your specialist. Great. Can GI symptoms cause an inguinal hernia? Not necessarily, but if you're coughing a lot because you're vomiting or aspirating and coughing increases the chance of a hernia, but it's usually not mistaken for GI involvement, because inguinal hernia is outside of your gut. It's outside of your abdomen. It's in your groin. Terrible itch, retaining fluid for about a week. Itch is driving you crazy. Sorry to hear that. Lots of reasons. If it's just a week, it could be anything. If it's long term, who knows? But I think if it's bothering you a lot, this is for Barb, then you might want to seek medical attention. So Barb, that's a great question. Yep. Okay. With the liver issue, where does itching occur? Everywhere. It's because of bile salts, and sometimes we give Questran, which is cholestyramine for that, but not necessarily. You need a diagnosis if you're really itchy, or at least to rule out some reasons. If your skin's really inflamed, and now with COVID, we got to wash a million times more than we used to and use astringent things, you can be itchier because you're really dry. So if you're dry all over your body and itchy and dry, then I say bathe less, use good moisturizers. But if you had a shower normally once a day or every other day, have it a bit less often. Does hiatus hernia exacerbate GI issues? It can, because you can have more acid reflux from that. And hiatus hernia is common, but if you have acid reflux and a hiatus hernia, there's more pressure pushing upward, so it can make the swallowing tube issues worse, acid reflux and heartburn worse. I think, so can GI problems somehow increase Raynaud's? We kind of talked about, if you're getting blood flow to your gut, you can constrict on the outside of your blood vessels, which is your peripheral blood vessels, like your hands and your feet. So maybe, should you get your hernia repaired? You're going to have to ask someone, because a general surgeon, if it's really mild, no. If it's moderate or severe, maybe. Severe diverticulitis could be, so you can get pseudo diverticuli from scleroderma, which aren't the infection of diverticulitis. They're little outpoachings going through the lamina layer into the muscular layer of the bowel, poaching out, whereas diverticulitis is, diverticulosis is the whole thing poaching out. So maybe not necessarily, but having diverticulitis on top of this is a bad issue. You guys have had wonderful questions. I wonder if I think I've addressed them, and we're at 2:00 on the dot, which is amazing. So I might hand it over to Scleroderma Atlantic.
Thank you very much, Dr. Pope. That was excellent. When we go to our monthly meetups, there are a lot of questions all the time and a lot of discussions around the GI and what works for some people and not for others. So this has been an absolutely excellent educational session for us, and we all thank you very much. We'd also like to thank our sponsors, the Government of Canada's Emergency Community Support Fund and the Community Foundation of Nova Scotia. Just like to let you know that the slides will be available afterwards, but also the entire taping of this session, so that you'll be able to see the whole thing and hear Dr. Pope's words while you're looking at the slides, and not have to try to remember what she was saying when that slide was up. We will post the links to both of those on the Scleroderma Atlanta Facebook page, as well as our support group page for Scleroderma Atlantic, and that'll be within the next few days. So you're saying that Edith Brown is thanking Dr. Pope from the UK. That's excellent. This is a global problem that we have, and we're thankful that we have Dr. Pope's time when she has been so busy. So our next session is going to be about getting active, where to start, and how to keep going. And, you know, in terms of the gastro stuff, I don't like to exercise because I have to run to the toilet all the time. So hopefully this where to start and how to keep going will be a multifaceted instructional seminar with more than just one presenter. There's going to be a few different people, some who are able to keep fit all the time, some people that are on oxygen and have to be much more cognizant of their capabilities. And that one will be Sunday, April 18th, 2 p.m. Atlantic Standard Time. We hope that you can join us. And once again, thank you, Dr. Pope. You're great.
Great. Thank you, everyone. Try to enjoy spring. It's really coming. And thanks for your great questions and attendance. Bye-bye.
Bye now.